You're watching Cetome TV. Knowledge is power. So now we're going to switch gears and go into a very specific spotlight focus on breast cancer. And there's a couple of questions to start with, and then I know you've prepared some information you want to share as well, and I've got some questions to ask you too.
Yes, so, I didn't really prepare much, but I'm going to be winging it.
Okay, well, I've got lots of questions for you because I'm very curious about this topic. So first question is from Sherry. Do men ever get ER-positive breast cancer?
Yes, they do. Yes, definitely.
Okay. Actually, so that's the quick answer, but let's back up the bus to what the heck is ER positive? What does that even mean? Because that's a term we hear a lot to do with breast cancer.
Yes. So ER refers to estrogen receptor,
okay.
ER, estrogen receptor. And so breast cancers are typically based on the expression of certain receptors. So you have the estrogen receptor, you have the progesterone receptor, and then you have what's called the HER2 receptor, human epidermal growth factor receptor. And so they're all basically the same family. They're receptors that are on the outside of the cell, and they respond and create genetic signaling based on what binds those receptors. And so in the case of the estrogen receptor, that would be estrogen.
Okay.
And progesterone, that would be progesterone.
So if I have estrogen positive cancer, what does that mean?
That means estrogen is capable of stimulating the growth of your cancer.
Okay. And same with HER2?
Yes,
exactly. Okay. I've also heard terms like triple negative.
Yes.
So what's that?
The triple negative is if you don't have any of those receptors.
Oh, the estrogen, progesterone, or HER2.
And then there's also triple positive, which is something we see a lot of too.
That doesn't sound good.
And that's where you have all three.
Okay. So there's three mechanisms that are making cancer happen.
Yeah, it gets very confusing quickly.
Sure.
It's hard to treat.
Yeah. Okay. Here's a question. Is there a specific genetic mutation that causes ER-positive breast cancer? Does BRCA1 or 2 have anything to do with it?
Yeah, so the BRCA1 and 2 genes, as most people know, they're involved in DNA repair. So every time your cell copies itself, every time the DNA gets damaged, these genes are involved in making sure to maintain the integrity of the genome. So if you have damage in your BRCA1 and 2, then obviously you're going to be incorporating these mutations into your cells as they copy themselves and as you age and in response to the environment. And so therefore you have all of these genetic aberrations.
Yeah, more vulnerable.
And it's just a matter of time before one happens in a cancer-causing gene.
Okay, that makes sense. So we were talking earlier about how just because BRCA as a gene is talked about a lot to do with breast cancer, that doesn't mean that that's the only cancers in which it's involved or found.
No, it's involved in many different cancers, and there's also a bunch of different genes in that signaling pathway. So it's now what we do is we don't just look at the BRCA1 and 2, we look at the genes that are part of that process that they use, and that is referred to as BRCA-ness.
Oh,
so there's a bunch of different having a quality of the BRCA signaling pathway.
Okay.
And so there's lots of new studies. You know, some drugs will work better with some of those BRCA-ness mutations than others. You know, for example, and you could have multiple mutations in those signaling pathways. You know, not just necessarily just 1 or 2 genes. You could have 3 or 4 gene mutations and so on. So
and what would
go on there?
Why does it matter if I have one? I mean, if my pathway is damaged, what difference does it make if I have 1 mutation or 3 or 4 there? How does that help me to know?
Well, your cancer is going to be more aggressive with the more mutations you have, and it's gonna not respond to standard treatments as well.
Okay, because there's other influences.
It's going to respond really well to standard treatments, depending on whether the treatment is the right treatment for that particular set of mutations.
Which again, we have to do the genetic testing to find out what mutations are driving the cancer, and then find the right targeted therapy for those mutations. Knowledge is supreme power.
Yes.
Yeah, absolutely. Good question, Liz. Thank you. Okay. Sarah wants to know, what are the best treatments for ER positive breast cancer?
That's a great question, and there's been some amazing new developments in breast cancer in the last few years, especially estrogen positive, but also triple negative, and definitely HER2. We've seen so many incredible advances just in the last few years, and once we find a targeted pathway that works, most companies start building drugs for it.
Mm-hmm.
So one of the things that we look at with sequencing is we look at a set of pathways that are fairly important. The first pathway is a PIK3CA pathway. And so if you have mutations in this pathway, there's a new drug called alpelisib, and it targets that. And when you combine it with an estrogen blocker such as fulvestrant, it works quite well, and especially in advanced patients, it gives them more time. So that is one of the new pathways that's really nice. And we're specifically focusing on ER positive breast cancers right now. It's very different for triple negatives and triple positives.
Okay.
So PIK3CA is for ER positive. And then there's also BRCA1 and 2. Yeah. And for them, PARP inhibitors, but also there's some indication that even for estrogen positive breast cancers that don't normally respond well to immune therapy like PD-1 inhibitors, if you use a combination therapy with a PARP inhibitor and immunotherapy, and you have a BRCA mutation or something, there is a tendency for a much better response in those patients. And then, of course, we have HER2 mutations, which is one of the newest things. So normally in HER2 positive breast cancer, what they do is they count the copies of the HER2 gene, and it's called, well, how many different HER2 receptors you have, and that's called overexpression of HER2. But what we know now is that you can get mutations in actual HER2 gene. So the gene itself can be mutated. And when you have mutations in the gene, then it kind of overrides the signaling pathways that the estrogen inhibitors are blocking, and it opens up an alternate pathway. So there's a new drug for that called neratinib, and that also blocks a PIK pathway too. So neratinib is really important. So whenever we see an estrogen positive breast cancer patient, and they've had breast cancer for many years, and all of a sudden they stop responding, their cancers start coming back, one of the first things we do is we look for either a PIK mutation or we look for a HER2 mutation. So both of these classes are emerging mutations.
And there are targeted therapies for them.
Targeted therapies for them, yes.
Yeah. Was there more you wanted to add about that before I interrupted you? No? Okay. All right. So let's see here. Why don't we talk, just back up the bus a little bit from the topic of treatments and just talk a little bit about some of the common symptoms or things that people, might be able to be on the lookout for themselves for breast cancer, and what to do if they see them.
Well, I think the best thing to do is go to your doctor for that. Definitely there's many different signs of breast cancer. If you have any suspicion, get a PET CT. Don't waste your time with mammograms or anything. Definitely get a PET CT. Do not waste your time with x-rays.
That's a good point. The ultrasounds, the mammograms, the x-rays are not going to tell you definitively that you do or don't have cancer.
Right, exactly.
Yeah. So, okay, so I'm still going to drill down a little bit into this question here, because there's I would imagine either as a potential breast cancer patient, I'm going to either notice lumps or I'm going to notice lesions.
Right.
One or the other?
Yes. And you're going to notice changes in your nipples. You're going to notice changes in all sorts of things. So I think that's I think just being observant and pain, obviously. Although really I don't like to go by symptoms. Because some people are strong and tough and they just ignore the symptoms, or they're out of touch with their bodies. And they just ignore the symptoms. So I think it's really important that if you feel different or if you feel something, be aggressive. Catching it early is everything.
Right. Insist on a PET CT, yes, because that's a type of imaging technology that's going to allow you to find out right away,
Right.
whether you do or don't have cancer, and where throughout your body, not just that one particular area that they might look at with an X-ray or an ultrasound. Yeah, but that requires, for starters, PET CTs cost some money, depending on where you live, what country you're in. In the United States, they're less expensive and far more accessible.
Yes.
They're often ordered as a matter of course. In Canada, they're not ordered for cancer diagnosis unless patients really insist on them. And even then, it's really dependent on your doctor and their understanding of PET CT and how valuable it is and whether they're able to get that for you based on what their province allows or doesn't allow. But there are private PET CT clinics in the United States and Canada and elsewhere in the world if your medical system doesn't provide them for you, and they cost anywhere from, depending on where you live, they can cost anywhere from about $1,800 to $3,500.
And you don't need a high dose CT scan. You know, you can just get a just the PET imaging by itself is good enough. Even PET with an X-ray is good enough.
Well, that's good to know. So you might save some money and
cut down
on your radiation.
Yeah, you definitely want to cut down your radiation. Yes.
Yeah. One of the things that I've read about PET CT versus CT is that because of the conclusiveness that PET CT can offer that a CT scan can't, and how they can tell you right away and you don't need repeated scans for contrast, you ultimately end up getting less radiation if you use PET CT for monitoring than CT scan.
Yes. So any kind of imaging like CT scan requires serial scans. So in other words, they measure the tumor at one point, or what they suspect to be a tumor. They don't know if it's a tumor or not, and so they measure it, and then if it grows, then they say it's a tumor, and if it doesn't, then they say it's benign.
Right. So there's at least a 3 to 6 month window in there while they're waiting
and getting
for the
multiple
next
scans.
test for contrasting.
Yeah, I think that's an excellent point.
Yeah.
Yes. Whereas with the PET CT, obviously, it's a one shot. You know that day.
Yes. So with a lot of things to do with cancer care right now, anywhere in the world, there are so many options for very thorough diagnoses, for targeted treatment plans. It's really just a matter of how assertive you're going to be on your own behalf, and whether you're going to add some extra research or testing to the treatment plan that your oncologist is preparing for you, or whether you're going to go simply with their recommendation. And these scans are a great example where, again, depending on where you live, some of our clients have been able to get PET CTs paid for within their healthcare system or insurance coverage. Others have had to pay out of pocket. Some doctors have refused to prescribe them, and other doctors prescribe them as a matter of course. The science is pretty sound that they, as we've just said, will tell you very quickly whether you do or don't have cancer, except in a couple of cases, right? There are a few cancers that aren't so easily detected by PET CT. Is that right?
Yeah,
like
I think that's changing.
Cancer? Or is that changing?
No, yeah, that's changing. Yeah, they're coming out with different isotopes and so on. So.
Oh, wow. Okay. So I just learned something new there. Yeah. So these things that used to be hard to detect with a PET CT are not so conclusive. We don't even need to worry about that anymore.
Well, I think there's some cancers that are more PET avid than others, but I think all cancers at an advanced stage are fairly aggressive and visible through a PET. Yeah.
All right. Well, that's good to know. Okay. So let's see here. What are some of the risk factors for breast cancer?
Oh, that's a great one. Well, your fat content for estrogen positive breast cancer is very, very important.
So how much extra weight I have on my body? Is that what you mean?
Fat. Your fat ratio. Yeah. So the risk for estrogen positive breast cancer goes up by 35% for every 5 kilograms of overweight you are. So that's fairly significant.
Goes up by how much?
35%.
Wow.
For 5 kilograms.
Holy schmoly.
And that's cumulative.
Wow. And that's my understanding of how fat happens is I take in food that's not so good for me or more than I physically need to, and then kind of the toxins in that food, let's say it's a lot of sugar or something like that, they get kind of surrounded by these fat cells. Was that right?
No, fat cells typically store toxins. Yes.
Yeah.
So yeah, They don't get surrounded by them. They actually store it in the fat cells.
Oh, they store it.
Yes.
Okay. So
it's a way of inactivating
the
carcinogens and the toxins, is to surround them with fat.
Right. So, and then at some point those toxins come out is the problem.
Yeah, or they're just sitting there leaching or converting the fat cells. They can convert fat cells into tumor cells.
Oh, so okay. So that, all right. So it's not
there's a lot that can happen there.
All right. So if we can keep the toxins that we're putting into our body to a minimum and keep our weight down.
No, because fat cells by nature produce estrogen. So that's one of the biggest factors there.
I did not know that.
Yes, and it's the same with ovarian cancer and other cancers. In fact, just having a strip of fat around your midline can drastically increase your risks for ovarian cancers.
Wow, because the fat cells themselves
are releasing estrogen in that area.
Okay, and the more estrogen, not so good. Yeah. Wow. Okay. So weight, having extra fat on your body is a risk factor. What else? Anything else for breast cancer? Are these inherited mutations?
Inherited mutations, smoking.
Okay.
Alcoholism, drugs, the standards.
Okay, right. So if we tone down the smoking, tone down the drinking, keep the recreational drug use to a minimum, eat well, exercise moderately, we are statistically 80+% of the way to preventing cancer.
Yes.
Exactly. Yeah, there's a lot of power we have over that.
Yes.
Yeah, okay. Let's see here. Okay, so let's talk about some of the folks that you've worked with in the past who have had breast cancer and how some of those situations have gone. Yeah. So there's one particular lady that came to mind by the name of Lisa. And that was quite an interesting case where some mistakes had been made that needed to be corrected.
Yeah.
And it all turned out well.
Well, how much time do we have?
We have enough time to make a start. Okay. Anyway.
Yes. I would prefer to take this moment and just talk about one of the new therapies that I think is really important to breast cancer.
Oh, sure. You're the expert. Tell us what you think
Lisa,
we would most benefit.
Well, this directly applies to Lisa too.
Okay.
So there's been a lot in the news recently about something called CDK4/6 inhibitors.
Okay.
They are referred to as estrogen inhibitor enhancers, although they probably work on multiple different levels. And they end with a lib on the end of them. So there's palbociclib, ribociclib, and abemaciclib.
Okay. And
so these are basically all different companies competing for the best drug.
And what did you say they are again? There's inhibit something?
So they're called CDK4/6 inhibitors.
Okay.
And that's just a process in the pathway of that's common with estrogen-positive breast cancers.
Okay.
So what's really important about these drugs is they really make a huge difference in women with breast cancer. But Canada is really regulating them and making it very difficult for women to access these drugs. It's a real problem. Palbociclib, we started using palbociclib many years ago, and we use it with fulvestrant. And fulvestrant is another drug that's very important. It's a newer version estrogen inhibitor. And the important thing with fulvestrant is not that, so most estrogen inhibitors inhibit the production of estrogen. So they're called aromatase inhibitors. And aromatase is a pathway involved of creating estrogen molecules.
Okay. So most of those drugs try to reduce the amount of estrogen you have, basically.
Yes. Which is not necessarily the best way to go, because estrogen has positive and negative roles in the body. And that is because there's two different receptors for estrogen. There's what we call the estrogen alpha and the estrogen beta receptor. And so the estrogen alpha receptor causes things to grow fast, and this is what's overexpressed in your breasts during your menstruation cycle. And so estrogen beta is quite the opposite. It actually causes a reduction in proliferation and growth. And so estrogen triggers both of them.
Right. So you don't want to be taking them both out.
Exactly. One is actually cancer preventative, the estrogen beta, and one is cancer promotive, estrogen alpha. So fulvestrant is a great way of targeting this approach, because fulvestrant, instead of preventing the production of estrogen, what it actually does is it prevents the cancer signaling aspect. So in other words, the estrogen alpha pathway. And so what it does is it binds onto the estrogen alpha receptor on the outside of breast cancer cells, and it prevents estrogen from binding there. So it's like a steric inhibition. In other words, it binds onto the receptor, and estrogen now can't bind to that alpha receptor, but it still allows it to bind to the beta receptor. And so you get certain aspects of signaling.
Wow.
So fulvestrant,
Wow.
we've been using that for many years, and it's a great drug.
Wow.
So that works incredibly well with CDK4/6 inhibitors. And these CDK4/6 inhibitors are really changing the landscape of breast cancer treatment, both in advanced breast cancers and in starting out in early stage.
Right, so they're like literally lifesavers.
But interestingly enough, they're different. So each drug has a completely different side of benefits and disadvantages. So the first one was palbociclib, and that was a great drug. It works very well, minimal side effects. And then they came out with a drug called ribociclib. So ribociclib works slightly different. It's from a different company, obviously, and but it works very well. But it also works in women who've already had palbociclib. So if they've had palbociclib, typically if you get a drug and then it stops working and then you go off it, you can't get it again. It's not going to work again, and that's kind of the general knowledge. But that's not necessarily the case with this class of drugs. So you could go off the drug, you can do some different drugs, and then you could come back to it and still get a benefit from it. And this is something that most doctors don't know.
And why is that?
We're not entirely sure. There's many different reasons. But what's important is you can actually cycle through these drugs. So you could start with palbociclib, and then if it stops working, then you could go to ribociclib, right? Now, the problem with ribociclib that the others don't have is it requires heart monitoring. So there can be, one of its side effects is on certain aspects of how the heart functions.
Okay.
It's not that common, but you want to be monitored if you're on ribociclib. That's not necessarily as true with the palbociclib or the latest one, abemaciclib. Now, abemaciclib is the latest one, and it's the one that really works. It's one of my favorites. It has the least amount of research, but it's really a great drug because it's able to cross the blood-brain barrier. The other two drugs aren't able to cross the blood-brain barrier as well. They can, but not as well. And so,
what's the value of that?
Well, if you have brain metastasis, this drug can actually get into your brain and or your spine. A lot of women get spinal tumors and so on, causing back pain and so on. So, this drug can enter the CNS, the central nervous system, and it has great effects there. So, so that, and also because of the design of this drug, abemaciclib, you can take it every day. You don't have to take a break of it once a month. So palbociclib and ribociclib, you do, I believe, 21 days, and then you take a break, and then you go back on it. With abemaciclib, you can take it every day. And so that break that you have to take every month with the other two drugs is when the cancers are going to start growing back and metastasizing and taking over.
And with this most current one,
you're able to get a metronomic sequencing. And any drug that is given in a metronomic sequencing is going to work better than a drug that's given intermittently.
Right, because the cancer cells just don't have time to come back in the same way, right?
Yes.
So what you're saying is not only are there these new innovative treatments, but you can take one and then move on to the next and the next, and
exactly.
Essentially, you
can cycle back and forth with them,
for a good long time.
Well, it seems to be, It seems to be that you can actually go back to palbociclib after doing the abemaciclib and still get some minimal benefits. Not extensive, but it's a benefit. It's extra time. Now, there are interesting mutations that will benefit some of those drugs and inhibit some of those drugs. So, for example, if you have an RB1 mutation, very common in estrogen-positive breast cancers, it's a tumor suppressor gene. If you have that, then it reduces the benefits of palbociclib and ribociclib, but not abemaciclib.
Right.
So once again, this boils back to the importance of sequencing, getting tumor DNA sequencing, so you know which one of those drugs, and this is a classic example where you have 3 drugs that target the same pathway. They're all made by different drug companies, but different mutations will affect each one of those drugs differently. Some will benefit it, some will inhibit the benefits of it. So once again, regardless of what you're doing, even if you're doing the same class of drugs, you need to know what mutations you have. It's everything.
And then whomever is on your treatment team needs to be able to interpret that information and know.
And incorporate into your treatment plan. You know, hey, you have an RV1 mutation. You've been approved for a CDK4/6 inhibitor, but ribociclib and palbociclib are not going to work as well for you. You need to be on abemaciclib first.
Right. So,
or you have a brain metastasis, you need to be on abemaciclib. Or you don't have any of these, you can start off on palbociclib.
Right. So that genetic testing really is key.
And especially in these targeted therapies.
Yes, right.
But I think what this really focuses on is that it's not just the mutations that the drug is targeting that you need to look at. It's the other mutations that may interfere with how that drug targets that mutation.
Right. Which is why the spot testing, or just testing for BRCA1, for example.
Targeted sequencing.
Yes. Right. Okay.
Targeted
layperson language here.
Targeted mutation
All right.
testing.
Targeted mutation testing. So we're just picking one, like BRCA1, for example. While that it's better than nothing by all means to know, but there could be other genes that are going to influence how that works, or other genes that are more aggressive and influence how your treatment works.
Or that dictate that you need to add a second drug to increase the benefits of it. So, I think what we focus a lot on as a company, and we spend most of our time focusing on, anyone could tell you, hey, this drug for this mutation. Foundation One does that on its tests, but it does not tell you whether there's a mutation that you have here that will prevent that drug from working on that mutation. So the interacting mutations is everything.
Yeah, it's very complex.
And it gets very complex quickly, and you need a company like us that has experience in genetic signaling and cancer signaling to be able to determine what drug and what combination of drugs are going to be best for you. It's very important.
Yeah, this time is of the essence, and you don't want to get treatments that aren't going to be the best for you.
Definitely not.
That it often leads to increased side effects and again, just less effectiveness.
Yes.
Yeah. Okay. Was there anything else that you wanted us to know about breast cancer, whether prevention or treatment or things to look out for? I know there's
sequencing.
The topic is yes.
There's many things we could talk about, but we've run out of time.
Okay, so short answer. If you think you might have breast cancer, any type of cancer, a PET CT really is from a diagnostic speed and seeing with your own eyes whether you do or don't and where and how aggressive. That's really the best diagnostic tool for starters. And then if you do, then definitely you want to make sure that you get a genetic testing panel, not just like hundreds of genes looked at, not just one or two.
So for interacting mutations.
Right, covering all those bases. And then what we see so often when people have those genetic panel tests done is that they don't just have one or two mutations.
No, they have many.
For the vast majority of people have a handful, 20. We even had somebody recently who had 100.
Almost 300.
Almost 300 mutations.
Yes.
So, which interestingly enough, was a good thing for this person.
It is, because it indicates that they're going to get a high chance of responding to immunotherapy. And this is in a cancer that typically doesn't respond to immunotherapy. Neuroendocrine.
Yeah. So don't be thinking the more mutations, the worst, or I don't want to know because there's nothing that can be done. There's tons that can be done.
Yeah, the more mutations, the more opportunities.
Yeah, there's laws and new treatments being developed all the time. So even if there isn't the perfect treatment for you today, literally next month
could be next month. Yes,
yeah.
Exactly.
Yes.
Thank you for watching CTOME TV. Subscribe below and stay informed.